Welcome, everybody. It's a pleasure to have you here. I think this is our it's our last talk for the quarter. Um, it's been a busy quarter, and I hope you all have enjoyed the speakers. We take a break in the winter quarter, but we will be back in the spring. We have a great lineup for the spring. So I hope you will block off now your Tuesday at noon at 12:30 time slot. So, because this has been a great crowd, and I hope you'll all come back in the spring if you're able. Today I want to introduce Dr. Nisha Beharie. It's my great pleasure to do that. She's an assistant professor in the Department of Public Health in the School of Health Sciences and Practice in the New York Medical College. Prior to that, she was a senior research associate in the New York City Department of Health and Mental Hygiene, which we had the opportunity to talk with her over dinner last night about that experience a bit. I mean, she was there during COVID, so pretty striking and interesting times for her. So I don't know if I assume we'll have lots of questions about what she presents to us today, but that might be something you could ask about as well. But her research highlights the importance of giving voice to marginalized communities of people with substance use or substance use disorder and those experiencing homelessness. She has numerous publications on substance use disorder and the importance of harm reduction approaches and on how such approaches could be modified to greater effectiveness. Today, she will share with us, I think, some results from her larger study on trauma, mental health, and substance use among homeless families. And one of the main findings from that, which I don't know if she'll get into or not because it's a larger study, but is the importance of the shelter environment and promoting positive psychosocial outcomes for homeless families in New York City. So very excited to have her with us today, and please welcome me and join me in welcoming her.
Hi, thank you so much. It's a real pleasure to be with you here today. I'd like to thank Dr. Colleen Grogan and Dr. Shelby Stewart and the Crown School of Social Work Policy and Practice and CHAS and Keith Brown as well for their assistance and their invitation to come and present with you today. So as you see, the title of my talk is Housing as Health Policies to Better Serve People Experiencing Homelessness. So I'd like to kind of set the context for my talk by saying that, the theme for this talk series was access to healthcare, right? And so I want to start with the premise that housing is healthcare, right? We know that it helps to improve a lot of health and mental health outcomes and reduce negative ones as well, right? And this quote helps to exemplify that a little bit, or really conveys that sentiment well by saying the primary and essential function of housing to provide safe and sheltered space is absolutely fundamental to people's health and well-being. So homelessness in America increased 12% from 2022 to 2023, and we're now reaching the highest point since 2007, which was the first year that the data was collected. And roughly 1 in 5,000 Americans were considered homeless in 2023. Not surprisingly, there are racial disparities in homelessness. Black Americans represent 37% of homeless population, despite being only 13% of the US population. And concurrently, housing assistance has reached the lowest point in 25 years. In New York City, in particular, the number of longer-term New Yorkers sleeping in the shelters each night increased by 19% from 2022 to 2023. And on any given night, there are roughly 350,000 individuals who are considered homeless. 200,000 of them are considered sleeping up or doubled up or tripled up. Another 100,000 are in shelters, and thousands more are sleeping unsheltered in public spaces. And around 4,000 are sleeping in unsheltered public spaces. So how did we get here? Between 1980 and 1987, $45 billion was allotted to subsidize publicly owned housing, and that was lost between those two, the 1980 and 1987. And that was due to budget cuts under President Ronald Reagan. We've never really recovered from that since then, but there have been responses to address that. The first of which was McKinney-Vento, or McKinney Homelessness Assistance Act, which then became the McKinney-Vento Act of 1987, which was and still is the only piece of federal legislation related to homelessness. There was also advocacy related to homelessness, as people kind of really wanted to push to address the issue. And an example of that was the Housing Now March in Washington, D.C. in 1989. And since then, there's been a steady decrease in available of affordable housing, which of course, with of course the increase in cost of living. And the COVID-19 pandemic more recently has of course created a lot of new issues related to housing due to loss of jobs and instability, financial instability. So I mentioned the McKinney-Vento Act. The McKinney-Vento Homeless Act provided funding for a wide range of services, including primary mental health care, substance abuse treatment services, educational services, social services, and job training. And with educational services in particular, one of the things that it did is it allowed students to stay in the same school that they were in prior to becoming homeless, or move to one that's closer to the shelter. And so while it's really great to have that flexibility, it proves to be a big challenge still for homeless families, which I'll talk about in a moment. It also called for the establishment of an interagency council on homelessness, and it put forth a comprehensive definition of homelessness as well. So another approach that we've taken nationally is a housing first approach. So a housing first approach declares that first and above all, people who are homeless need housing, which I think we can all agree on, and that you move people who are homeless directly from the streets into, or wherever they're living, that is unstable, into permanent supportive housing where treatment services are available if they should need them. And not all families need either substance use or mental health treatment services, but that they're available for them if they need them. But that participation in such services is not mandatory. So, you know, as you may know, like there are several instances, or you know, the model up until then, and still exists, is that you have certain requirements that need to be met in order to maintain your housing. One of those is that often that you're sober, or you know, making appointments to various medical offices, or you're going to your meetings and the like. And so this is sort of saying you have housing whether or not you do those other things. And the premise is that housing alone will improve the new tenants' health and social well-being, and will improve the use of primary care and outpatient services, and will reduce the utilization of hospitals, jails, and emergency services, because housing is healthcare, right? So that basis of just providing housing is an essential function, and one that has a really important effect on health. So in New York City, we have the right to shelter mandate, which was established in 1981 under Callahan versus Carey, and requires the provision of shelter for anyone who needs or requests it, or who requests it, anyone in need who requests it. And we are somewhat unique, not that other jurisdictions don't attempt to find shelter for people who need it and worked hard to do that, but we're one of the very few across the country that actually have that on the books. The other two jurisdictions in the United States that do have such a mandate are Washington, D.C. and Massachusetts. And in Washington, D.C., It only applies during times of extreme temperatures, and in Massachusetts, it only applies to families with children as well. And in terms of New York City's response in particular, of course, we have housing assistance programs. So we have FEPS, which is the Family Homeless and Eviction Prevention Supplement, for families who receive cash assistance and are facing eviction or who have lost their housing due to domestic violence, health or safety issues, or court decisions. We also have city FEPS, which are for families up to 200% of the federal poverty level that are at risk of homelessness or are currently living in a shelter. We also have the PATH office, which is the central office for families seeking a space in the shelter. And that is, I'm bringing this up because I'm going to revisit it in some of the findings that I present to you later. And there's only one office in the city for homeless families, and it's located in the southern part of the most northern borough in New York City, the Bronx. And so if you are a family, that's the only place that you can really go to try to find a shelter space. And it can pose a big challenge if you have many kids and you live in a borough far away and are trying to navigate getting them to school and to work. We also have Section 8 housing, which is a federal program, but we have it in New York City as well, of course. And it's also known as the Housing Choice Voucher, which is more recently supplemented with the Emergency Housing Voucher, EHV program, through the American Rescue Plan Act. We have HIV/AIDS Services Administration, or HACA housing for those who are living with HIV/AIDS, and HUD-VASH for veterans. So this is a list of rules that family shelter, those residents living in family shelters in particular, and this is a shelter that is run by a nonprofit, that they have to kind of abide by while they're staying there. And the rules that I wanted to point out really quickly are that children must be supervised at all times, which is an important rule. We want to keep kids safe, but at the same time, it poses a challenge for older youth because they aren't able to kind of explore or take those developmental steps towards independence, towards being alone in their wherever they're living, or coming and going as they would want. So it poses a challenge for older kids. You're required to sign in and out of the desk, and the units are furnished, but there are often strict regulations in terms of what you can bring into the shelters, or what sort of electronics you can bring into the shelters, or appliances. In particular, air conditioners are not allowed almost across the board in shelters, which can be obviously a huge challenge for families when they're in the middle of summer in the heat and they have asthmatic children or are asthmatic themselves. You also, I think I want to go back really quick. And the units are regularly inspected by staff as well. So if you can imagine someone coming in your house, right, on a regular basis and inspecting your unit, and it's not a fun thing to have to go through. These are the DHS rules, the Department of Homeless Services, and the rules that I wanted to point out here, that these are, there are rights that are listed for the tenants. You have the right to receive visitors in common areas in particular hours and days of the week. So you can, but it's restricted, right? And you can't just have them over whenever you want. You have the right to leave and return to the facility within the curfew hours, so you do have to abide by curfew times, and that can be a challenge for families that are trying to find night jobs or trying to find work that doesn't always fit the 9-to-5 schedule. You can only bring 2 bags into the shelter, and which is per resident, and so that is not a lot if you think about trying to uproot yourself and all of your belongings. You have residents residents are monitored. Their dress is monitored, and so that can be kind of an uncomfortable situation for them too. That they can't just kind of walk around the way they would walk around in their own home. And again, they're responsible for supervising their children, which of course is important and keeps them safe, but presents challenges for older youth. So why focus on family homelessness? So a picture is worth 1,000 words, and I'm a big fan of pictures. And this figure here, I think, does a really good job of illustrating over the past, how over the past 3 decades or so, we've seen exponential growth in family homelessness in New York City. And of course, that's not unique to New York City alone. And I also wanted to note that 71% of those living in municipal shelters were members of homeless families. So they represent the preponderance of folks living in shelters. I became interested in looking at these dynamics between the shelter environment and mental health and other psychosocial outcomes for homeless caregivers and youth while I was co-directing a NIDA-funded program with families in shelters where we were implementing a family-based curriculum to reduce HIV/AIDS and substance use, or to prevent HIV/AIDS transmission and substance use. And I just kind of quickly realized that they had a lot of other obviously pressing issues on their minds other than HIV/AIDS and substance use often, because a lot of times, they're just trying to pay their bills and find housing, of course, and that's first and foremost on their minds. And so for my dissertation, these are findings from part of my dissertation. I looked at that data set, which the name of the project was HIV Prevention Outreach for Parents and Early Adolescents, to better understand that association between perceptions of the social environment and various outcomes, and the way that the residents were interacting with rules as well. So these are just findings from caregivers, and from the caregiver part of the sample, 209 caregivers. And the first aim of this particular part of the analysis was to test the association between caregiver mental health and perceptions of the social environment of the shelter, and to test the association between caregiver mental health and difficulty following shelter rules. So the 4 items that I used for that to measure the social environment of the shelter were: do you feel safe at the shelter? Are there things for people to do at the shelter? Are there things for families to do together at the shelter? And does the shelter staff help you and your family? And so you can see that the average score of 3 with the range of 0 to 4 kind of indicated that they did feel like the social environment of the shelter wasn't completely horrible and abysmal for them. But when I looked at the relationship between the perception of social environment and mental health, there was an inverse relationship. So in other words, if you had a better perception or a more positive perception of the social environment of the shelter, you had less mental health symptomology, and vice versa. And similarly with difficulty with rules, there was actually a positive association, which sounds counterintuitive, meaning that if you had difficulty following shelter rules, you had less mental health symptomology. But the way I interpret that is that these caregivers and families were coming to the shelter with their own rules and their own ways of doing things, and their own family kind of dynamics and routines, and the rules oftentimes conflicted with that or didn't allow them to carry out those kind of routines that they already had with their families. As a postdoc, I also wanted to look at the effect of homelessness or the relationship of homelessness and trauma. And so myself and 2 other colleagues looked at the joint effect of child abuse and homelessness on substance use. And the first aim of that study was to assess the differences in prevalence of trauma among those who had experienced homelessness versus those who had not, to determine whether early experiences of homelessness were a correlate of drug use during emerging adulthood and adulthood, and to assess whether a joint impact exists between experiencing homelessness and childhood sexual or physical abuse on drug use during emerging adulthood and into adulthood. And to carry out this study, we used the National Longitudinal Study of Adolescent to Adult Health, or AdHealth. And it's a nationally representative longitudinal study of US adolescents. And we used 3 waves. The first wave was represented adolescence, the third wave represented emerging adulthood, and the fourth wave represented adulthood. The final sample included almost 13,000 individuals that had participated in all 3 of those waves and had valid sample weights. So the independent variables in the models were having experienced homelessness, having experienced child abuse before the age of 18, and other forms of trauma that were modeled after the ACEs. So the items weren't exactly the same items that were on the ACE item, or the ACE scale, the Adverse Childhood Event Scale, which you may be familiar with, but included neglect, emotional abuse, parental incarceration, parental binge drinking, witnessing violence, threats of violence, and experience of violence. And the dependent variables were related to substance use at wave 3 and wave 4, and included binge drinking, marijuana use, cocaine use, methamphetamine use, and prescription medication use. And the reason we took this focus on substance use is I was in a NIDA-funded postdoc, and substance use in general has kind of been an increasing interest of mine, and so that was the reason why we chose these outcomes, but we could probably be looking at a lot of other different outcomes as well, and it would be interesting to see the results of those as well. The covariates in the model included age, race, education, gender, and poverty, and that was measured in terms of reported difficulty paying bills. And for the analysis, we accounted for stratification, clustering, and unequal selection of probabilities, yielding a nationally representative estimate. And for AIM-1 and AIM-2, we used weighted prevalences and bivariable analyses. And for AIM-3, we used multivariable analyses and logistic regression. And we looked at adjusted and unadjusted models for the multivariable analyses. So for the bivariable analyses, when we looked at prevalence of homelessness by demographics, not surprisingly, we found those who were male, those who were between the ages of 16 and 17, and those who had experienced poverty were more likely to have reported homelessness or have reported experiencing homelessness, and those who had completed more than a high school degree were less likely to have experienced homelessness. So not too new there or surprising. And then this was interesting because we got to see sort of in a nationally representative sample how many had experienced homelessness, and that was only 4%, but within that 4%, 82% had never stayed in a shelter, which kind of conveys the sense that homelessness can come in many forms, right? Not just living in a shelter, obviously. It can include being doubled up and living outside on the streets, yes, but there are many other forms of homelessness that often are not as visible. And when we looked at the relationship between trauma and homelessness, there were strong associations fairly pretty much across the board with all of the different traumatic experiences, but in particular with emotional abuse, physical abuse, threats of violence, and experience of violence. And when we looked at the relationship between substance use and homelessness, again, not surprisingly, we saw strong associations between homelessness and substance use, and in particular with cocaine use and methamphetamine use. And this carried on at wave 4 as well, or persisted into wave 4, although it attenuated slightly. And in wave 4, marijuana and methamphetamines proved to have the strongest associations in that wave as well. So the multivariable analyses are presented here, and I want to point out 3 things. I know it's a lot to look at, so I'm going to try to walk you through it. but we compared those who had not experienced a childhood abuse and had not experienced homeless to those who had experienced just childhood abuse and just homelessness and both. And so that's indicated by the A, the H, and the B. If you can see those, hopefully you can. I know the pointer doesn't work too well, but basically what you're seeing here is that the middle point estimate with the confidence intervals, which is what you're seeing there with the dots and the line, the middle one is typically higher, right? And those are individual, then those are typically higher than the ones who had just experienced childhood abuse alone, which is the one that's on the far left, right, of the three, when you see it, the three groupings. And so that indicates that there were stronger associations with being just having experienced homelessness than just having experienced childhood abuse. And so, you know, when you think about prevention or homelessness prevention among children and youth, you see that this can have an impact on substance use. And so it's important to intervene early on to prevent homelessness for these negative outcomes, one of them being substance use, right? The other thing I wanted to point out is that there seemed to be an additive effect, not necessarily multiplicative effect, but an additive effect of childhood abuse and homelessness. So that's shown by the way that the three dots and lines kind of go up in a staircase kind of way for the most part. And the adjusted models and unadjusted models are fairly similar in most cases as well. And the strength of associations did attenuate again into wave 4 from wave 3, but still persisted for the most part. And so we see that this is fairly consistent throughout all of the different substances there. So as a postdoc, I also applied for pilot funding through the Center for Drug Use and HIV/AIDS Research, and to study in more of a mixed methods, using a more mixed methods approach, how this dynamics plays out in shelters in terms of the shelter environment and psychosocial outcomes, but also what are some points of intervention that we can leverage to improve the lives of those in family shelters. So these were the mentors. These were my mentors for the project, Noah Leonard and Maria Guad and Carolyn Dorson. And I was able to hire 2 staff, Kirby Jean and Hadiza Suji as well, to help with the data collection analysis. And I also want to just quickly acknowledge the participating families and staff that were working in the shelters that we partnered with. Their feedback was incredibly valuable, and I'm thankful that they shared with us. I'd also like to, of course, thank the Center for Drug Use and HIV Research for the funding for the project. So the specific aims of the research were to explore the relationships among various contextual factors, so policy, family, shelter, and youth risk-taking, to determine potential points of intervention, to propose policy and programming recommendations for families residing in homeless shelters that are aimed at reducing drug use and sexual risk-taking among youth. And we carried the first 2 aims out by conducting a mixed method study guided by the triadic theory of influence, or TTI, and incorporating an iterative process, which I'll explain in a moment. So we start with contextual influences with the TTI. So we had contextual influences at different levels, right? So we have the family level, the shelter environment level, and then the larger city, state, and federal policy level. And we hypothesized that modifying the shelter environment in various ways, having parent interventions and youth interventions, would ultimately create more egalitarian governance, improve parent mental health, and reduction in substance use, which would then directly impact youth substance use and indirectly impact youth substance use through positive parenting. The first phase of the study, we elicited initial intervention ideas at one shelter through focus groups and in-depth interviews with residents using qualitative methods and through quantitative methods by implementing a survey with all participants.
Oh, God.
For the second
The
phase,
presenter
and this is
has
where
a
the iterative
typo in her
part of the process came into play. We elicited responses to those initial ideas and elicited new ones as well through just in-depth interviews at the second shelter with residents and staff, and implementing a quantitative survey as well with all residents. And in total, there were, for both phases, we included 18 caregivers, 13 staff, and 10 youth between the ages of 13 to 17. So not a huge sample, but I was really struck by how, especially the qualitative data, really brought to light what their experiences are and their struggles are, and really helped to pinpoint maybe what some interventions might be that would help families living in shelters, but also some that wouldn't also. The surveys included topics related to sociodemographics, of course, aspects of the shelter environment, much like included the 4 items that I mentioned before, and also several others that I'll show you in a moment. Policies related to homelessness, shelter rules, both caregivers and staff responded to those questions. Services within shelters, mental health, and measured by the brief symptom inventory. Parenting stress is measured by the Parenting Stress Index, and monitoring and supervision and communication, as well as adverse childhood experiences and neighborhood experiences, and more particularly kind of negative things that were happening in the shelter or the neighborhood surrounding the shelter. Topics covered in the interviews and focus groups related to challenges that families faced with shelter rules, how experiences of policies, how they experienced policies related to homelessness, and suggestions for interventions and policies that would support parents and encourage the healthy development of youth. So for the analysis, we used a convergent parallel design where we collected and analyzed the qualitative and quantitative data separately, but at the same time. And then we analyzed the quantitative and qualitative data separately. And then for the final stage of the analysis, we compared and contrasted the quantitative and qualitative data together. The caregivers were largely female, so 76% of them identified as being female with a mean age of 36, and many of them did have kind of older youth age children, but for the most part, a lot of the caregivers in the shelter are younger typically and have younger kids. And so a lot of times these youth are outnumbered, and there, as you'll see in a moment, there are not as many services for them, and they sort of get lost in the shuffle. In terms of caregiver race, 53% identified as Black, and 23%, roughly a third of them identified as Latinx or Latino. And less than half had completed a GED or a high school diploma. And 65% reported not working, which is not surprising, but almost another third did report actually working either full-time or part-time, which kind of speaks to this idea that these were largely families that just couldn't pay their bills, and it wasn't necessarily largely because of mental health issues and substance use that they were homeless, that largely the mental health issues came after, right, and because of the struggles they were facing. So the mean age of youth was 16, and 67% were male, so kind of flips, right? There were more male male youth in this sample than in terms of when compared to caregivers. And 89% of the youth identified as Black, with 11% identifying as Latino or Latinx. And almost 50% had completed 11th grade, which is sort of on par with their average age of 16, which hopefully means they were at grade level. They traveled roughly an hour to get to school, which is not surprising for New York City. You can travel a while to get to school, but still is a long time and a burden for sure. And only a third were in the same school that they were in prior to coming into the shelter. So as I had mentioned with the McKinney-Vento Act, you did have that choice, and a lot of them were opting to come to a school closer to the shelter, which is probably more convenient, but also means they need to cut ties with a lot of the relationships that they had in their old school. Interestingly, 65% of the caregivers reported that this was their first time in the shelter, and about 50% said that they had been in the shelter for about 11 to 12 months, which is pretty much on par with the average shelter length of stay for families, which is over 400 days right now. 69% of staff identified as female, 69% also identified as Black, with 23% identifying Hispanic, and 8% as white. There was a wide range of roles that these staff came from that we interviewed, which was great. We had a program director, we had an after-school program director, medical staff, psychiatrist, residential aide, psychologist, benefits counselor, porter, maintenance staff, and administrative assistant. The average time of working the shelter that they reported was almost 3 years, with a pretty wide range of 1 week to 17 years, and 2 staff members actually had reported experiencing homelessness themselves in the past, which was interesting and speaks to this really kind of gray area where people who were working in the shelters did have that experience, and it kind of sometimes helped to bridge that gap between the staff and the residents that might exist there. So here you have the prevalences of ACEs among caregivers and youth, and on the left you see the prevalences of caregivers, and I just wanted to note that for both youth and the caregivers, the ACE6, which is divorce, is the highest, the most prevalent, 50%, which I think is pretty much on par with what it is for the larger population. I think we always say, one out of 2 divorces, or 1 out of 2 marriages ends in divorce, or something of the sort, right? But the ACE1 and ACE2 were related to childhood abuse, and in particular emotional and physical abuse. And ACE 8 and 9 were related to living or growing up in a household where people were struggling with substance use and or mental health issues as well. So you notice on the right, the youth didn't really endorse many experiences of childhood trauma. They were, youth, so they were, pretty close to almost being 18. I'm not sure why they didn't. I mean, I guess it's a good thing if that's true. But it was something that is definitely noteworthy. So here, this is the full list of items that we use to measure the shelter environment. And so on the far left here, you have questions related to their relationships with friends in the shelter and staff in the shelter. And so you notice that the youth felt that they were reported being friends twice as much with staff as the caregivers did, which is not surprising because there was often animosity between the caregivers and shelter staff. For question 2, I'm friends with other people who live in the shelter. You can see that both youth and the caregivers did kind of endorse high levels of that, which is great and really speaks to the community that they were creating for themselves in the shelter. For 6 and 7, this kind of conveys the sense that they had to cut ties with friends or people that they knew before living in the shelter when they moved, and that they didn't know very many people that were living in the shelter when they moved there. And then lastly, for Q9 and Q10, I just wanted to point out again that the concerns related to safety that they felt both inside the shelter and in the surrounding neighborhood as well. And in particular for youth, they were endorsing high levels of pretty scary things that they were experiencing right outside the neighborhood and the community. So 78% reported having heard about a shooting gallery near the shelter. 56% of the people in the neighborhood complained about being harassed by police, and 78% reported that there was a gang fight near their home. So in terms of parenting stress, you can see that there are pretty high levels of parenting stress, which is not surprising. Over 50% of caregivers reported were scored in above the 85th percentile for parenting stress, which is the cutoff point for high parenting stress. And the graph on the right is just a different form of depicting that. And it was pretty significant across the board with the other 3 domains of the scale as well. So here you have services that were available in the shelter, and I just want to point out 2 things. One is that a lot of the caregivers and even staff were not aware of all of the services that were available in the shelter, and and that there were a dearth of services for substance use and HIV care in particular as well. So when looking at the qualitative and quantitative results combined in the final part of the convergent parallel design analysis, we found that there was general distrust and disillusionment with government and government programs, that there are challenges with education, particularly among youth, that remain despite the McKinney-Vento Act that I've sort of alluded to. And there was a desire for greater autonomy among residents. There was a dearth of services for older youth residing in shelters, and the experience of homelessness could have been exacting a greater toll on youth relative to caregivers as well. So here's what we kind of ended up seeing all overall, where there was a trickling down effect of the negative impact of policies and rules, such that they were creating this kind of sense of disillusionment and trust and lack of trust, and loss of autonomy and strained relationships between residents and shelter staff, and loss of hope as well, which then led to parenting struggles and ultimately to poor school attendance, youth risk behavior, and residential mental health. And so we see that play out kind of anecdotally in the qualitative data in particular, but also to a certain degree with the quantitative data as well. So quantitatively, when we looked at disillusionment with government programs and services, 65% of the caregivers reported that they disagreed or strongly disagreed with the statement that city government is providing enough support to homeless families, but only 44% of youth disagreed or strongly disagreed with that same statement. Here's a quote from Stacy, a caregiver who was kind of telling me about her experience in the PATH office, which was, if you remember, the office that you go to in the South Bronx if you are in need of shelter and you're a family. And she felt that she was being mistreated by the PATH staff there. And so she said, you're going to end up losing your job, losing your home, and you're going to be in the line behind me because I'm going to be in front of you, because I'm no better than you and you're no better than me. So what, you got this job? You're human like I am. You think the president care about you? I know he doesn't care about me, and I don't care that he don't care about me because I've been taking care of myself before he became president. And it's worth noting that the president she's referring to is Trump, because he was in office at the time. And so something to keep in mind as we enter his second administration as well, in terms of the fact that they are paying attention to politics and they are very aware of how it is affecting their everyday lives as well. Here, Sasha, a caregiver, was also kind of lamenting about, more than lamenting, but expressing her frustration with the fact that she had been in the shelter and was really not feeling supported in finding permanent housing. And so she said, my problem is people that's in here